Hello everyone, this is Dr. TSR. So today I am here to share with you the guidelines regarding thyroid in pregnancy. This is Fogsi guideline and it is released in 2021. Okay, so here pregnancy, they have given pregnancy is a natural stress test for thyroid gland. So there is increased estrogen, increase in the when there is increase in the level of sex hormones. So what happens when there is sex hormones such as estrogen is increased in the body? So when sex hormones are increased, sex hormone binding globulin also increases. Like when estrogen increases, it will increase the thyroid binding globulin. So there will, even though there is more level of T4 and T3, but it will bind to thyroid binding globulin. So normal T4 and T3 will, free T4 and T3 will be normal in the pregnancy. That's what they have given. And because HCG is there, which is almost similar to that of TSH, it will stimulate the TSH. Hence, in first trimester, the level of TSH, what is the cutoff? Cutoff is very less. That is what they have given. Transient TSH reduces in 8 to 14 weeks. Then there is increased peripheral metabolism of thyroid hormone. So there will be decrease in the level of free T3 and free T4. Okay, even though thyroid, whatever the production is increased, and including thyroid binding globulin, which increases and binds all the T3, T4. So free T3 and free T4 tends to be in the normal range. But because of increased peripheral metabolism, there is again decrease in free T3 and free 4. And there is increase in the demand of T3, T4 by almost about 30 to 50%. Okay, and our fetal thyroid gland, whatever the fetus is there, that thyroid gland will start to function by 10 to 12 week. Before 10 to 12 week, the fetus solely depends on the mother for its thyroid hormone and for its utilization. So coming to the guidelines, so first trimester, as I already told in my short video, that is first trimester 2.5, second and third 3. So usually we have a practice of telling 2.5, 3. So what is the unit you should know? So that is milli international unit per liter. Okay, so that is the same thing from European guidelines also, 3 milli international unit per liter. So the recent ATA guidelines says it is for a specified pregnant population, use locally derived reference values. If there is not at all any reference value is available, consider upper TSH is up to 4 milli international unit per liter. Okay. So maternal hypothyroidism it is mainly due to autoimmunity or post-thyroidectomy status or iodine deficiency causing Hashimoto's thyroiditis, and incidence of overt hypothyroidism is 2.5%, and subclinical hypothyroidism is 2 to 7%. So thyroid antibodies are almost present in 60% of reproductive women. Okay, so what are the effects of thyroid in pregnancy? So anemia, preeclampsia, placental abnormalities, low birth weight, postpartum hemorrhage, myopathy. Fetal, there is cognitive impairment, neurological abnormalities, developmental abnormalities, congenital hypothyroidism, and in neonatal hyperbilirubinemia and respiratory distress. So pregnancies in women with subclinical hypothyroidism were 3 times more likely to be complicated because of placental abruption. That's what is most important. Thyroid abruption, thyroid hypothyroid abruption. And even preterm birth is almost 2 times higher. See, abruption is 3 times higher and preterm birth is 2 times higher in women with subclinical hypothyroidism. So coming to the management, during pregnancy, all patients with overt hypothyroidism with TSH more than 2.5 milli international unit per liter should be treated. Overt means the one with the symptoms. Okay. So what are the dose? This dose you should remember, that is 2 microgram per kg per day. It is 2 microgram per kg per day. So okay. So you have to maintain TSH below the 2.5 milli international unit per liter. So if she's already on hypothyroid drugs, then you have to increase the dose by 30% as soon as pregnancy is diagnosed. And we have to monitor the TSH regularly every 4 to 6 weeks until mid-gestation, and at least once you have to do it by 28 weeks. That's what, if the lady comes in first trimester and she has done a TSH, her TSH is normal. So you will leave like that only? Yes, but yes, we can leave, but we will usually repeat her TSH again in the third trimester. And if she is already a known case of thyroid complicating pregnancy and she is on tablets, then also we will repeat again in the third trimester. Nowadays it has become a trend that before giving anesthesia, before if we are planning electively also for a C-section, we will ask for TSH level, when was the last TSH done. So you have to remember, you have to repeat the TSH by the 28 weeks. Okay. So when it comes with subclinical hypothyroidism, means without any symptoms, subclinical hypothyroidism, they are telling it is usually recommended if a TSH is greater than 10 milli international unit per liter and TPO antibody is positive with a TSH between 4 to 10 milli international unit per liter. Thyroxine therapy we can consider even if the TPO antibody is negative and TSH is between 4 to 10 milli international unit per liter, and TPO antibody is positive in women between 2.5 to 4 milli international unit per liter. So in this guideline treatment, what they have told is, if the lady is coming with overt hypothyroidism, overt means the lady is presenting with the symptoms. She has symptoms of hypothyroidism. In that time, your cutoff is at the 2.533. That's what they are telling. So if TSH is less than 2.5, nothing you can do. More than 2.5, you start her treatment. If she is already on hypothyroid, you increase the dose by 30 to 60%. And you have to repeat her TSH again since she is on symptomatic lady. So you have to repeat again every 6 weeks or 4 to 6 weeks, and then at least once in 28 weeks of gestational age. Then when comes with management of subclinical hypothyroidism, means the lady where TSH simply you have done when she has become pregnant and you diagnose there is high level of TSH. Here they are telling if the TSH is more than 4 or if the TSH is more than 2.5 only, you do TPO antibody. If the TPO antibody is present and TSH is between 2.5 to 4, treat the lady. If TSH is between 4 to 10, you will again treat the lady. Okay, even if it is the TPO antibody positive or negative, more than 4 you will treat. Between 2.5 to 4, if TPO antibody is present, you will treat. And the dose of thyroxine what we give is per day 2 microgram per kg per day. Okay. So and in the postpartum period what they have told is you do it at 6 weeks. Some women where LT4 is initiated during pregnancy may not require LT4 postpartum. That is if the dose is less than 50 microgram per day. So and you have to evaluate in 6 weeks. Okay. This is what they are telling about management of hypothyroidism in pregnancy. Okay. Then coming to the hypothyroidism in pregnancy, here what they have told is the hormones namely T3, T4 circulate in the body. They are bound to thyroid binding globulin or transthyretin and albumin. And T4 is the thing which is found majority among the released hormones. The active form is also unbound version found in very small quantities and is labeled as free T4. And TSH is the one which is secreted from the anterior pituitary, helps in the production of thyroid hormone. So when there is hyperthyroidism, TSH is reduced and T3 is increased or in the normal range. Free T3 again increased or normal range. T4 again increased. So that is the thing. T3 and T4 is increased whereas TSH is decreased. That is the thing in hyperthyroidism. Same HCG interacts with the TSH receptors in the thyroid. So mimicking an effect for hyperthyroidism. During the first trimester of the pregnancy, rising levels of HCG are noted. So which causes reduced TSH and mild transient increase in the level of free T4. Hence, a continuous monitoring is indicated as TSH values would further fall back to their normal range in the second and third trimester due to decrease in the HCG levels. Coming to the causes of hyperthyroidism in pregnancy, mainly because of intrinsic cause to thyroid like Graves' disease, thyroid nodule, subacute thyroiditis. Pregnancy-induced like hyperemesis, hydatidiform mole and drug-induced. Coming to Graves' disease, which is an autoimmune disease pre-existing hyperthyroidism. It is autoimmune in nature. Thyroid stimulating antibody is the reason for the stimulation of thyroid gland resulting in Graves' disease. So symptoms such as sweating, palpitation, heat intolerance, weight loss and failure to gain weight and nausea. Signs such as tremors, warm extremities, tachycardia, proptosis and goiter. So in ECG what you can see is atrial fibrillation as an extremity. Okay, so algorithm for thyroid testing, what they have told TSH is increased, it is hypo. TSH is normal, nothing to do. TSH is decreased, check for free T4 level. Check for free T4 level. If free T4 is normal, check for free T3 level. If free T3 is also normal, it is subclinical hyperthyroid. If free T4 is increased, it is hyperthyroidism. Free T3 is increased, again it is hyperthyroidism. So what happens to the fetus? As I already told, the fetus starts to produce its thyroid hormones by 12th week of gestation age. So fetus is totally dependent on mother before 12 weeks of pregnancy. If there is uncontrolled hyperthyroidism, there may be IUGR and fetal tachycardia and goiter formation in the fetus, because TSH is very less. How come it can transfer to the baby? So there is IUGR, fetal tachy and goiter formation. Documentation of FHS for fetal tachy along with fetal thyroid size for fetal goiter should be done on obstetric scan, like in anomaly scan or close scan. Okay, so treatment for hyperthyroidism, we should give anti-thyroid drugs. The drugs which we know is propylthiouracil and methimazole. So can we give radioactive iodine? No, it is contraindicated during pregnancy. So the aim is to maintain a range of thyroid hormones at the upper limit of normal range, and you minimize the possible dosage of drugs. When it comes with propylthiouracil is safe in the first trimester of pregnancy, whereas methimazole is given during the second trimester of pregnancy. And liver function test has to be done because there is a risk of liver failure in patients who are treated with propylthiouracil. Okay, so propylthiouracil, the dosage is 300 to 450 mg per day, and it is administered orally in 3 divided doses. Maintenance dose 100 to 150 mg per day, and again it is administered orally in 3 divided doses. Graves' disease, the dose is 50 to 150 mg, again 3 times a day. Maintenance dose is 50 mg orally, again twice or 3 times a day. Coming to methimazole, the dosage is 15 to 40 mg per day orally in divided dose, and dosage of 60 mg per day used in severe cases, and maintenance dose is 5 to 30 mg per day. And Graves' disease in pregnancy, here the dose is 10 to 20 mg per day. Okay, and titration should be done based on the level of free T4 and not on TSH. Okay, because TSH values can change in first trimester, second or third. So the change in the dosage is depending on free T4 level. So once you have started the treatment for hypothyroidism, again you check same thing 4 to 6 weeks. I told in hypothyroidism, here it is every 4 weeks you have to check the TSH level and free T4 level. So any complications because of this anti-thyroid drugs like propylthiouracil, methimazole, look for simple like rash, fever, and severe like hepatitis, liver toxicity, SLE like syndrome, or egg granulocytosis. Okay. So management in postpartum period means in relapse of Graves' disease occurs in females within 3 months of their delivery because of disappearance of immunosuppression in the pregnancy, because pregnancy is a immunosuppressive state. Graves' disease will be suppressed. Once pregnancy is over, within 3 months there is relapse of Graves' disease. So then free TSH and free T4 need to be monitored at 6 weeks and 12 weeks. Having said this, propylthiouracil and methimazole, they are both excreted in the breast milk, and mainly propylthiouracil about 80% protein bound, whereas methimazole is non-protein bound and more lipid soluble. So this is in brief about hyperthyroidism in pregnancy. Now let us go for postpartum thyroiditis. When it comes with postpartum thyroiditis, it is because of destructive thyroiditis, mainly autoimmune condition. So it is something called painless thyroiditis also. It is a variant of Hashimoto's thyroiditis. So it may occur in 3 ways. One is transient hyperthyroidism, or transient hypothyroidism, or transient hyper followed by hypo and then recovery. So what happens is, so the initial thyroid inflammation damages the follicles. So when the follicles are damaged, activates the proteolysis of thyroglobulin stored within the follicles. So which causes, when there is thyroglobulin, which is a storage form which is undergone proteolysis, so there is release of large amount of T4 and T3 into the circulation. Therefore, there is hyperthyroidism, unregulated. So stores of thyroglobulin also gets exhausted. So then comes what? Transient hypothyroidism. Once all the levels are excreted, all are exhausted, so there is transient hypothyroidism and TSH level starts to increase. So thyroid follicle regenerate and thyroid hormone synthesis and secretions resume. and finally the thyroid functions becomes normal. So whatever happens in postpartum thyroiditis, it is painless, it occurs in postpartum, or it is subacute. So it's 20 to 30% of the individual in the postpartum, they have sequence of hyperthyroidism. Within 4 months of the delivery, it starts, and then followed by hypothyroidism, which lasts again for 2 to 6 weeks, and then followed by recovery. So remember, that is the very beautiful pathology given here. Once first there is follicle destruction, so thyroglobulin is proteolized, and hence there is unregulated release of T3 T4, which causes hyperthyroidism. After which, once the stores are exhausted, there is hypothyroidism. Then the follicles start to regenerate, and there comes the recovery. This is what is called as postpartum thyroiditis. Okay, so then 20 to 40% of the female who will have only hyperthyroidism within 2 to 6 months of the delivery. They have the symptoms like fatigue, weight loss, palpitation, heat intolerance, anxiety, irritability, and tachycardia, tremor. So but 40 to 50, most of them will have hypothyroidism, not hyper. So they have like lethargy, lack of energy, cold intolerance, constipation, dry skin. So most of the women in postpartum thyroiditis, they have mildly enlarged, diffuse non-tender thyroid gland, and their thyroid function is abnormal, so which disappears with the recovery. Okay, postpartum hypothyroidism may even decrease the milk volume. So when you do lab parameters, if it is hyperthyroidism, there is high or normal free T4 and T3, but TSH is low. If it is hypothyroidism, there is high TSH levels. And antithyroid antiperoxidase antibody concentration, they are high in 60 to 85% of the women with postpartum thyroiditis. Okay, so do you want to do FNAC? If FNAC is done, the HPE may show lymphocytic infiltration with collapsed follicles. Follicles are destructed, na? So there is collapsed follicle. Usually we will not do FNAC. So when it comes with the diagnosis, women with hypothyroidism, they are also main phone for postpartum depression. See, thyroid thing, antenatally we will be more worried about abruption, and when it comes with the fetus, we will be more worried about preterm birth and IUGR. So in postpartum, why are you worried? Because of depression. So nothing in OG, any complication will affect both in mother, fetus, and even in the postpartum. So we are more worried. So antenatally abruption, preterm, IUGR, postnatally depression. Okay, so when it comes with the differential diagnosis, you have to differentiate it from postpartum thyroiditis and Graves' disease. Thyroiditis postpartum period within 3 months, whereas Graves' disease more than 6 months post delivery. Okay, so here it is mild symptoms, here it is more symptoms, thyroid is more enlarged, and ophthalmopathy may be present. Here T4 is more increased, here free T3 is more increased. Okay, here antibody is not elevated, here antibody levels are elevated. When it comes with postpartum thyroiditis, so if she is asymptomatic, so no need of any treatment, monitor every 4 to 6 weeks. We are repeating again anyway TSH after 6 weeks. So asymptomatic hypothyroidism, if TSH is, again they are telling the same, if TSH is less than 10 ml international unit per liter, no need of any treatment. If she is symptomatic, you have to treat her with propranolol 40 to 120 mg or atenolol or metoprolol 25 to 50 mg, because we don't want tachycardia, right? If she is symptomatic, if the TSH is more than 10, or treat with T4 levothyroxine, so 50 to 100 microgram per day is what is required. Okay, that is in brief about postpartum thyroiditis. So then let's go for the last part, that is some myths which is related to thyroid disorders in pregnancy. So pregnancy is not possible with hypothyroidism? No, not at all. Subclinical hypothyroidism may be there, which may affect the ovulatory dysfunction, but it is not like pregnancy will not happen if there is hypothyroidism. Second thing, if TSH levels in pregnancy are in the normal ranges as per laboratory values, then there is no need for treatment. So all laboratory values should take the cutoff for pregnant women with her reference range. Okay. So if TSH is 0.5 to 5 milli international unit per liter as a normal reference for women. However, during pregnancy, it varies with the trimester. See, they have given first trimester if 0.6 to 3.4, and second 0.3 to 3.6, third 0.38 to 4 milli international unit per liter. Measurement of free T3 and free T3 T4 TPO antibodies are useful, and are recommended if TSH is more than 2.5. So that's what, if she is not having any symptoms, remember, if she is not having any symptom, if the TSH is less than 2.5 milli international unit per liter, you will do nothing. If the TSH is 2.5 to 10 milli international unit per liter or whatever, you will do what? You will check for TP1 antibodies, anti-TP1 antibodies. If TSH is between 2.5 to 4 and TP1 antibody is present, then you will treat. Okay. Or if between 4 to 10, irrespective of TP1 antibody present, you will treat. If it is between 2.5 to 4, TP1 is antibody is negative, they say there is no need to treat the patient. Okay, that's what they say in a case of women who are subclinical, like they are not symptomatic. That is what they are telling again and again. Okay, and elevated thyroid antibodies cause increased fetal loss and impacts neonatal health. Yeah, there will be increased fetal loss and preterm delivery, perinatal morbidity, LG infants reported in euthyroid women with elevated TP1 antibodies. But it is not clear that TP1 antibodies affect cognitive development, and they are at high. With the antibody, if they are elevated, they are at high risk of developing hypothyroidism, and hence TSH has to be measured every 4 weeks in the first trimester, and if stable, in once in each in case of second and third trimester. So it has an impact, but it is not, it will cause more of fetal loss. Okay. Then hyperemesis gravidarum causes hyperthyroidism in pregnancy. Yes, hyperemesis is because of increase in the HCG seen in hyperemesis. So it causes transient hyperthyroidism in early pregnancy, since HCG itself has a weak thyroid stimulating hormone activity. Then hypothyroidism can be responsible for excessive weight gain during pregnancy. Although thyroid is responsible, is the gland which is for metabolism, and it is rare for the patient to experience significant weight gain if they have such a untreated hypothyroidism. In severe hypothyroidism, there could be weight gain because of fluid retention, and this weight which is lost with thyroid hormone replacement. Excessive iodine is required during pregnancy to maintain normal thyroid function. Now, iodine requirements are higher in pregnant women due to increase in the maternal T4 production. Iodine deficiency is associated with hypothyroidism and goiter. Their diet should have 250 microgram. So they will ask na iodine RDA. What is iodine RDA? That is 250 microgram per day. Okay. So this requirement is there required even during lactation, but it is not the excessive iodine could be harmful. Soy-based products are detrimental to thyroid disorder. They will decrease the absorption of thyroid medication. So medication has to be taken first thing in the day in the empty stomach, but never with the meal. Gluten-free diet can help Hashimoto thyroiditis in pregnancy. Gluten-free diet cannot reverse the Hashimoto's. The myth is arise because celiac disease is common with Hashimoto's, and they benefits from excluding the gluten diet, but it is not with Hashimoto's. Thyroid medication is secreted in breast milk. Yes, small amount is secreted in the breast milk, but you have to continue the treatment during lactation, and it is not going to affect neonate too much, and adjust the dose according to the TSH level in the puerperium period. This is in brief about thyroid disorders complicating pregnancy 2021 guidelines by Fogsi, and this is the recent guidelines which is there in the website. So for more such guidelines and for more such videos, kindly subscribe to my channel, like, share and subscribe. Thank you.